I got it. I'll take care of that one. Good morning. In trying to keep things historic, they've asked me to do the administrative part of this morning's introductions. Very important note about the code for today. So the code, I think, is 27041, but it does not work right now. It is set because we were originally going to do this lecture tomorrow. It is set to engage tomorrow. So very, very importantly, if you try to register your attendance today, you will get denied. And if you forget tomorrow, there's no recovery. So you can do it. If you want attendance for today's lecture, you have to wait till tomorrow, and it's 27041. You can blame Dr. Lyons and Dr. Alabi because they're not here. So I would blame them. Yeah. That's very kind of you. Dr. Sweeney has generously offered to send out a reminder to the faculty listserv. Having some fond memories of some faculty having missed some of their CME and board stuff, I know it's always good to remind the faculty of these little things. But so that reminder will go out tomorrow. But you can't register for your attendance till tomorrow. Two quick congratulations, and I probably missed a few, but congratulations to Ken Cardona, who was just named to the inaugural NCI Sarcoma Committee. Really big, and congratulations to Ken. Congratulations to Kenesha Williams, who was selected for the Ascend program, which is a coaching and mentorship program. That's fantastic as well. And that's all I have for this morning. Reminder, banquet Saturday night. Congratulations to all of our outgoing trainees and all of that. And it's really a big celebration, which you'll hear a little bit more about in a minute. Yeah, I think that's everything I have. Good. Dr. Sweeney.
Thanks, Keith. I appreciate that, the updates, and thanks everyone for being here this morning. So good morning. It's a privilege and a profound honor to welcome you to this Department of Surgery Grand Rounds as we celebrate 100 years of surgical excellence at Emory. Over the past century, Emory Surgery has grown from a small academic unit into a nationally recognized leader in clinical care, education, research, and innovation. Our department has been shaped by generations of visionary leaders, talented trainees, and dedicated faculty who have advanced the frontiers of surgery while remaining committed to the highest standards of patient care. Today, we gather not only to reflect on our storied past, but also look forward to reaffirm our mission and embrace the challenges and opportunities of the next 100 years. It is my distinct pleasure to introduce our guest speaker for this centennial celebration, Dr. John Hunter, who is a towering figure in American surgery and a fitting presence for this historic occasion. Dr. Hunter was born in Hanover, New Hampshire. He attended college at Harvard, where he graduated cum laude with a degree in English literature. Medical school was at the University of Pennsylvania, and then completed surgical training at the University of Utah, followed by fellowships in surgical endoscopy at Mass General and the University of Western Ontario. After completing his training, Dr. Hunter returned to Utah to start the surgical endoscopy and minimally invasive surgery program in 1988. In 1992, Dr. Bill Wood was fortunate to attract Dr. Hunter to Emory in Atlanta. He served as chief of general and GI surgery from 1992 to 1998 and vice chair of surgery from 1995 to 2001. In 2001, Dr. Hunter was recruited to Oregon Health and Science University to become the McKenzie Chair of Surgery and Surgeon-in-Chief at OHSU Health System. He has served as interim dean of the School of Medicine in 2016 and 2017, then became the chief clinical officer and chair of the OHSU practice plan. And for 7 years, Dr. Hunter served as the executive vice president of OHSU and the chief executive officer for OHSU Health. He has served on the American Board of Surgery for over 13 years, chairing the board from 2016 to 2017. And he's been the president of several national and international surgical societies, including the Society of Surgery for the Alimentary Tract, SAGES, and the International Society of Surgery. Dr. Hunter is a pioneer in minimally invasive surgery, and his work has transformed surgical practice, particularly in gastrointestinal surgery, and it's established laparoscopy as a standard of care worldwide. In addition to his clinical innovations, Dr. Hunter has been a prolific academic, authoring hundreds of peer-reviewed articles and book chapters, and mentoring a generation of surgical leaders. His commitment to advancing surgical science and education exemplifies the values that we celebrate today. So please join me in warmly welcoming Dr. John Hunter.
Dr. Sweeney, thank you very much. It's a real thrill to be here, and I'm so honored to have been invited to give this lecture. I anticipated it would be fun to tell stories, but what I didn't necessarily anticipate was how much fun it would be to see people who I haven't seen for so many years. And just walking across the bridge or being at the coffee stand this morning and seeing Bob Guyton walk by and recall this many very hot summer days Bob and I spent on the tennis court over at the Druid Hills Club, where he soundly beat me almost every damn time. So anyway, it's great to be here. I just have a few disclosures before we start. I don't have any conflicts of interest relative to anything in this talk. The opinions that you'll see are just my own. And the stories may be slightly exaggerated by the benefit of 24 years away. But I do have the freedom to add a little bit of flavor to the telling. And there are some individuals in the room who can set me straight when I kind of go off the rails. So please feel free to do at the end if you are inclined to so do. So what I'm going to do here is just tell a series of what I consider illustrative stories about my time at Emory. It is a bit presumptuous of me to say that I was here for the birth of minimally invasive surgery, because we all know that the gynecologists and obstetricians were doing laparoscopy well before 1992. We know that the orthopedists were doing arthroscopy, which of course is video surgery, well in advance of that time too. But this is really sort of minimally invasive general surgery, GI surgery, and some of the other surgical specialties that sort of benefited from our work will be discussed as well. But what I hope to do is to sort of bring out some important principles, tenets, values along the way in these stories. One of them is trust, which I think is fundamental to any department of surgery and any practice of medicine. Collaboration and teamwork, record keeping, establishing a clinical database, keep track of what you do. A commitment to educating the next generation of surgeons, innovation, technique evolution, and in doing so, the management of risk, and you'll hear about some of that a little bit later. Humility, understanding when you made an error and stepping forward and admitting that you made an error and what you're going to do about it. And then curiosity, sort of asking the right questions. Dr. Sweeney will be glad with this, but it's very important to find financial support, not necessarily from the department, to help answer the questions. And there is support out there. Presenting and publishing the results, really critical, and we'll talk about that too. So what I want to start with is in 1992, which is when I was at the University of Utah doing some early work in minimally invasive surgery, thanks to George Bursey and John Dixon and some of my mentors in Utah. But it was a smallish place, and Intermountain Healthcare was the principal player in Salt Lake City. And with the work that we were doing, I had the opportunity to be recruited at quite a number of centers. And Emory was clearly the one I chose. And I think the question I want to start with is why Emory? And I think that Emory it's a rich tradition of the first 100 years, which at that point was more like 70 years or so. But it was a reputation that Emory had nationally. And I give Dean Warren a lot of credit for that. Bing Rickers, who was my mentor at Utah, was a portal hypertension surgeon and had trained here at Emory under Dean Warren. He said, "You go to Emory, that's the best of the jobs you've been offered. It's a fabulous place." But the real person I really want to sort of call out is Bill Wood. Bill, I crossed paths with at Mass General, where he was doing surgical oncology, and I did most of the colonoscopies for him. It's where I learned how to do colonoscopy. But Bill exemplified gentility and trust. And my offer letter from Bill Wood was 2 sentences. You will come in as an associate professor of surgery. You will make, I don't know, I can't remember what it was, but it wasn't much money. And that was it, and there was no other, there was a title, I think, associated with it, but it was about a 3-sentence letter. And one had to trust that. And I trusted Bill Wood, and he trusted me, and he had my back for the whole time. And I can tell you that there were some times when he needed to have my back. So what was the assignment? What was the recruiting package? Atlanta was really a hotbed of minimally invasive surgery, but it was really emerging in the private sector. And billboards like this were greeted me when I drove into Atlanta for the first time, where centers were trying to attract people for hiatal hernia surgery. And Dr. Wood had managed to get Ethicon to agree to set up a $500,000 grant to help recruit. And with that money, the requirements or the expectations for me were to build a laboratory, to teach courses in minimally invasive surgery, educate the residents, support other faculty members who needed to and were interested in learning, outfit the ORs appropriately, to be engaged in research and innovation. And really, the most fun was to establish Emory as a world leader in minimally invasive surgery, which I think you've all done, and it was a pleasure for me to start off down that path. I think the other thing that was very important, because I was very interested in gastroesophageal reflux, was this article, which was published in 1992. As you just noticed, I came here in 1992, and just before I came, Stu Speckler, who's become a longtime friend of mine, a gastroenterologist from Dallas, published this article in the New England Journal of Medicine that basically said, in men with complicated gastroesophageal reflux disease, surgery is significantly more effective than medical therapy. Well, that was spectacular for a gastroenterologist publishing something like that in the New England Journal of Medicine. And so I said, I think there's an opportunity here to build a strong surgical program in reflux disease, which is so prevalent in the South. I think everyone in Macon, Georgia has reflux, by the way. At the same time, and this was published a little bit later, but at the same time as all that, we were working on how to do an effective, competent, safe laparoscopic anti-reflux operation. And Alf Kucheri was working with myself and Bruce Wolf, Lee Swanstrom, and Bill Hudson with the gastroenterologists who supported us. But that was published shortly after I arrived. So putting those two things together, I said, okay, there's one element that I really need, and that's a gastroenterologist at Emory who believes in the concept of surgeons taking care of reflux disease. And that gastroenterologist was Pat Wareham. And I know Pat's, I think, over at Piedmont now, I think maybe retired, but Pat was spectacular. And together we put together something that we called the Swallowing Center, and it was a one-of-a-kind multi-D clinic, loosely fashioned after what they had done at Hopkins, although Hopkins was mostly a otolaryngology practice. But this was GI medicine, GI surgery, otolaryngology, radiology, endoscopy, and a very strong GI function physiology lab. we spent a lot of time in outreach to GI docs all over the Southeast, Louisiana to Florida, Tennessee to South Carolina, and we're able to establish quite a referral base. At one point, this attracted the attention of CNN. And before I tell this story, I got to say that the swallowing center was just a corridor in the GI clinic. It was just, on Tuesdays we got together and we saw patients together. That was the swallowing center. And so CNN was in, they were doing a story, they were interviewing Pat, they were interviewing me, they were interviewing a patient. And the story ran for about a year or two on CNN. And at the end of it, they said, let's go see the swallowing center. I want to take some footage of the swallowing center. And this look came across my face like, oh my God, there's no real swallowing center. And so I looked at my watch and I said, well, it's 5 o'clock. I think the swallowing center's closed and everybody's gone home. So anyway, we dodged that question, and they never had to own up that we really didn't have a place. But it doesn't matter. You don't have to have a place. You have to have a concept, and you have to have a commitment. So we set out to put a database together right from the start, which would track physiologic parameters as well as historical parameters, outcomes, and et cetera. We had that managed by an RN, Kathy Galloway, for a long time, paid off grants from industry foundations, some federal grants. One of the critical things for the residents and junior faculty in setting up these databases is really make sure you stick to the essential elements. There are no nice to haves or it gets too crowded, too complex, too unwieldy. From that database, no fewer than 50 to 100 papers, and I think there's probably more than that, but I'm not even sure, were generated. So, what did Ethicon get out of all this? Well, Ethicon got a lab here on the campus, which they were used generously to teach laparoscopy to surgeons from around the South. They also got the harmonic scalpel. And the story there is that we were doing some work with a company out of Rhode Island called Ultracision, which is a small company, and they developed this technology. Dr. Swanstrom and myself realized that this would be spectacular for taking down the short gastric vessels, which were cumbersome to take down with clips. And the clips would sometimes fall off, and then they'd bleed, and the spleen would bleed, and it was just a mess. This was sort of revolutionary. And because Ethicon was in our OR a lot, they saw this, and before long, they started poking around the edges to see whether they were interested in buying it. And so they asked me to do a case and bring it to their boardroom in the J&J boardroom in New Jersey, which through a video link. And they were all sitting around the board room, and they're asking me questions as I was doing this case. And they said, well, what's the real advantage? I said, well, the real advantage is that you can mobilize the fundus of the stomach completely, and it will sit behind the stomach where the fundoplication is without any tension. And that's something that you don't see any other way. And so I brought the stomach around behind, and I said, see it sitting there, and all of a sudden the stomach retracts to the other side. This falls off the other side. And then a very loud voice, I use the F word, over the video link to the J&J boardroom, and there's a silence up there, and then all of a sudden everybody broke out laughing because everybody knows exactly how that happens. But anyway, the other story linked to this was a surgeon from the West who knew that he had a hiatal hernia, and one day he trained here at Emory, by the way, and knew of our work at Emory. And one day he was doing push-ups and he felt something pop, and lo and behold, he now had a paraesophageal hernia and was very concerned about strangulation and incarceration. So, called me up, said I need to be fixed immediately. And I said, well, we kind of can do this electively, and my schedule is pretty full, but I do have one slot on Wednesday where we're doing a case that we're broadcasting to the Ethicon headquarters in Cincinnati. If you're willing to be on a video link to a lot of trainees, that's fine. And so he said, sure. So he comes, we do the case, it goes fine. And then 1 week later, he's giving the oral boards in Phoenix. and he asks the resident a question about a paraesophageal hernia repair. And the resident goes on, and he says, well, how do you know all this? She said, well, last week I was sitting in a room in Cincinnati, and this guy from Atlanta was doing this case. And so he goes, well, how did it go? So this is a very small world. The lesson there, it's a very small world in surgery. So everybody's related to everybody. All right. So I want to talk a little bit about education now. So changing gears a little bit. When I was still in Utah, I got a call from a remarkable woman at Yale, a Icelandic woman who had a couple of years left on her visa. Her name was Margaret Oddsdottir. And Margaret said, I have got 2 years left after finishing my residency at Yale, and I want to learn laparoscopy to take back to Iceland. Can I come with you out to the University of Utah? And I said, well, that's great, but I'm not going to be there. And so I called Bill Wood, and Bill Wood said, we'll make a faculty position, junior faculty position for her. And so she was arguably the first MIS fellow in the nation. And she came with me, started in 1992 at Emory, and was here for 2 years. And she contributed quite a bit to the field. One of the things she contributed was what's commonly known as the shoe shine maneuver, which is performed in every fundoplication. That's how she described it to people. She also she was pregnant with twins and developed unique trocar positions for doing laparoscopy during pregnancy. And they were all sort of spread out on the side, and they worked perfectly. But it was really a very important contribution to the field, little less known. But Margaret, unfortunately, as you can see here, passed away of breast cancer at a very early age. And she has been remembered in a number of ways. One is that Yale has put together a lecture in her honor. Sages has a traveling fellowship in her honor, and we dedicated an issue of Schwartz to her as well. But she was a remarkable woman and should not be forgotten. So when I came to Emory, Emory was a really, one of the best known, one of the most accomplished centers for cardiac surgery, and remains so thanks to Dr. Guyton and his colleagues. And most of the residents at Emory wanted to go into cardiac. I could not get a resident to come into the operating room to learn laparoscopy. So that's part of the reason why we really needed to develop the fellowship was I needed a second set of hands, and I saw an opportunity. But after a few years, the residents really did see the light, and by the end of the decade, we had lots of residents who were enjoying our time in the laparoscopic suite with us. And the first Emory resident to do the laparoscopic fellowship was Tony Kim. Tony's now in Puyallup, Washington. But he came to me and said, I want to do the fellowship. And I said, you're a pretty darn good laparoscopic surgeon. You don't really need to do it. He said, I think I can mature. And lo and behold, just watching someone over the course of that year go from being, competent to being an expert was really quite something. And then, of course, the more recent graduate, I don't know if Priya here, I thought Priya was involved somehow in what's that? She's coming? Okay, yeah. So Priya was one of your residents, as many of you know, who came out to Oregon and was our fellow now in Phoenix. But she was a great fellow. So thank you very much for training her so well. Probably the really the acme, the pinnacle of my experience at Emory was being offered and honored by getting the Dick Amerson Teaching Award. And I think the text here says it. I don't need to read it to you, but there is no greater honor. And I probably had to leave to get it, by the way, but that was so. I would not suggest to any of you to do that in order to be so awarded. So I'm going to switch gears just a little bit and talk about some of the other stories that went on. And as I said earlier, we were working under a grant from Ethicon, which was very, very nice. That we had attracted the attention of U.S. Surgical as well as Ethicon. And when the 3 years was up from the original grant and we were time to renew, it became clear that U.S. Surgical, now Medtronic, was also interested. And I show the picture of Johnny Rockets here because Bill Weldon, who became the CEO of J&J, but at that time was the head of Ethicon Endosurgery, flew down to Atlanta, put on a T-shirt, and he and I went down to Johnny Rockets and we talked about what it could all look like. Well, that seemed like, and I really liked Bill Weldon, and I really liked Johnny Rockets, and it was a very good meeting. But little did I know that this gentleman, Leon Hirsch, was making a play directly to Dr. Wood, and Leon Hirsch showed up in front of this building out here in a very long stretch limousine with a whole cadre of individuals, and made a deal that no one could refuse, which was a offer of a $10 million research and education, including the funding of a chair, which I put forward in the name of Dean Warren, which I think Juan Sarmiento now holds. So it's really a pleasure to be able to use industry money to help fund a very important position for the Department of Surgery. But that also, of course, allowed us to fund many other developments and support the fellowship as we went along. I do want to call out a few other individuals and other programs who were really great to work with, and I think that the sort of work that we were doing with first Ethicon and U.S. Surgical and Storts and some of the other companies, Stryker, were very helpful in pushing the field in other areas. And I'm not sure exactly who deserves the most credit for the endoscopic saphenous vein harvest, but I know Alan Lumsden was very keen on it as the chief of vascular surgery. And Alan, of course, went to Houston. I searched hard, Chris, for a picture of Alan smiling, and I could not find one. But this sort of this enigmatic smile was the best I could do. But it was funny because he was actually hilarious and laughed a lot. But you look for photos of him, it's hard to find one of him smiling. But so you know, the minimally invasive surgery bug really caught on in lots of the specialty areas, and this was one in vascular surgery. Of course, endovascular surgery was being developed at the same time, and that, of course, is how much of vascular surgery is performed currently. But the plastic surgeons really caught on well also, and were very interested in how they could use video surgery to do cosmetic surgery, to do breast surgery, to do reconstructive surgery. I think Monty Eves developed much of the credit for that. Fouad Nahai, of course, was also involved. But it was really the leadership of John Bostwick, who was really just a fabulous individual. For those of you who knew him, was really driving that an incredible program in plastic surgery then and now here at Emory. And the third one I want to just call out, and I could call out probably all of the sections and divisions of surgery here at Emory, but the orthopedic surgeons, the spine surgeons, Heller and Horton, as what they were known, and I think there's Bill and John are still here, were very interested in how to do anterior fusion. And thank God they've kind of moved to posterior, because it was one of the hairiest operations done possible, trying to provide exposure laparoscopically between the confluence of the iliac veins with these huge drills and things. I don't know, has anybody here ever done an exposure for them like that? Are they still doing them? No, okay. I think I've looked and followed this field a little bit, and it's all been either open or gone to the posterior approach. So just a few minutes to sort of reflect on things that might not have gone so well, and I think this is all part of innovation. It's all part of sort of reflection on your practice. they say that in surgery, good judgment comes from experience, and experience comes from bad judgment. So I just wanted to show a couple of things that we learned along the way. One of which is that when you take care of an epiphrenic diverticulum, as you see here, make sure it's empty, because the sound of a stapler going across lettuce is the sound that you never really want to hear. And I'll say no more about it than that. Another situation which people may not know as well, and we fixed lots of giant paraesophageal hernias, but had a little old lady from North Georgia who had an active ulcer at the time we fixed her paraesophageal hernia, and lo and behold, 5 days later, while she's at home, she's eating pea soup, and the ulcer perforates. And taking pea soup out of the abdomen is not pleasant in an 85-year-old woman. So there are things that you need to learn and need to sort of reflect upon as you go along, and you need people like Bill Wood to say, this is part of what happens. And so I really am deeply indebted to Emory and to Bill for all of that. But I want to then move and finish up here with a discussion of really what drives me every day, which is discovery. How do you make things better for people through surgery? And I'm going to start with a study that we actually started at. We did this mostly here, although concept may have come through in Utah, which was to discover whether it was better to do an open or laparoscopic appendectomy. And that may be a stupid question for everybody in this room, but it wasn't at the time. The question was, is this something that one should randomize or not? And generally speaking, if you have two treatments, especially two surgical treatments with some equipoise where it's not clear, what's the best treatment, then the randomized trial is clearly the right thing to do. And I would argue that in much of robotic surgery, there really isn't that clear answer, and yet it's very hard to find funding to do such trials in laparoscopy versus robotics. But it was not that hard to find funding to do a trial where we compared laparoscopic to open appendectomy. And this was supported by US Surgical. I think the other lesson with this trial, you notice that I'm not the first author on this, even though we started this trial. Most of the patients were put on by USC, Adrian Ortega and his group at LA County put on more patients than we did. And his chair said, why don't you just publish this independently? You did you put on most patients. And it was really a challenge to keep the group together. But the solution we arrived at that was acceptable to their chair was that he would be the first author on the article, and I would present it at the SSAT meeting. And so, it's really important, and these studies are always difficult to do, but you got to do them. And you can see almost 600 citations. It's the most frequently cited article in the literature on laparoscopy versus open for appendectomy. So, the next lesson here is to publish everything. There's no research that you do that shouldn't be published, and there's a journal for everything. It may not be a high quality journal, but there's a journal for almost everything that you do. You got to make sure it's novel. I think many of you know, and I think John may have said this, I edited the World Journal of Surgery for 15 years. Thank you very much, Sandra Long, for all your help with the World Journal of Surgery. Many of you also in the room. So many studies that we turned down were Me Too studies. And those observations of studies rarely change the field. But you should publish new observations, new techniques, major improvements in old techniques. That's sort of the coin of the realm. And present at the big meetings. Not just at your specialty meetings. And I learned this from Yashir Kawitz, who said, what made plastic surgery at Emory was presenting at the Southern Surgical, presenting at the American Surgical, publishing in Annals of Surgery. Publish at the publish in the big journals and present at the big meetings. And then again, publish in the most widely read journals. So I'm going to spend a little time just sort of going through some of those contributions that came out of Emory that we were able to do. And I think when you do this work, your work becomes standard setting. And standard setting in surgery is not easy to do, but it's really important if you can do it. And publishing in Annals and New England Journal often allows that. So here are a couple of articles. One from both of these were from my time in Utah, but they sort of led to, these were just unique observations, and especially the first one was really what are the steps necessary to prevent a bile duct injury. This was then picked up and made much simpler by Steve Strasberg with the critical view. But I really think that probably the best descriptor was out of Bruce Wolfe, which would say, make the gallbladder look like a polyp on the stalk. You can make the gallbladder look like a polyp on the stalk before you put a clip on anything. You're never going to injure the bile duct. And so that's essentially what the critical view is. And then we've had to find a way to take care of common bile duct stones. I had the gastroenterologist in Utah who did all the ERCPs turned up with a bile duct stone, so he couldn't do his own ERCP. And so he asked whether I could get his stone out at the time I did the lap chole. So we said, well, we probably can, and took a basket from the urologist and a fluoroscope. And so the irony of this was about 3 weeks ago, I was at a small community hospital where they didn't have a cholecystoscope, and a patient turned up with an incidental bile duct stone. So I found the basket from the urology section in the fluoroscope and took it out. So you can, what goes around comes around. Steve Archer, a fellow here at this point, at the time, presented the American Surgical, a paper on laparoscopic bile duct injury and how residency training affected that. And thankfully, residency training would reduce significantly the incidence of bile duct injury. And that was been cited by almost 700. And then working with Larry Way, Larry was at UCSF, spectacular surgeon, and he and I worked together a lot on prevention of bile duct injury. And this Larry presented at the American Surgical as well, and you can see 1,200 citations for that article. So this is important to write about it, to observe it, and present and publish in reputable journals. The two presentations of the American Surgical, I think I mentioned standard setting. I think these help sort of set the standard for two diseases that we saw commonly. One was, of course, GERD, and this was a paper that we published and presented at the American Surgical, and then another one that a year later that we presented at American Surgical on helemyotomy. But some of the interesting work and some of the best work was done by the fellows. And Ted Truss, who was an interim chair at Dartmouth, I think his son is starting here as a resident in a few days, published this article, which I think was really sort of showed what anti-reflux surgery did. And this little spidergram here down in the corner, if you can kind of, I think I have a second to go through it. But on the inner circle are two circles, one of patients who had their symptoms controlled with PPIs, one of the patients whose symptoms were not controlled, the inner one with PPIs. But both groups, after effective anti-reflux surgery, brought their scores back to normal quality of life scores. And this was probably the most dramatic demonstration of what anti-reflux surgery could do for patients. And again, was published in Annals, and several other Me Too papers, by the way, were published after that, so confirming that finding. Another thing to do that I think is important is to understand where controversy lies, and then bring that back from a meeting if there's a vigorous debate at a meeting about any kind of controversy. and sit down and say, is there a way that we can answer this question? Can we put this controversy to rest? And there are some that you can't put to rest, routine versus selective cholangiography. And that's never going to be put to rest. But there are some you can. And this was one that we thought we could probably put to rest because the surgeons were standing up in a regular fashion and saying, well, anti-reflux surgery prevents the development of cancer in Barrett's esophagus. And it was data such as these that came, I think this was a Swedish study, that showed that if 15 patients had prior anti-reflux surgery, none of them developed dysplasia or cancer. And then the patients who had not had anti-reflux surgery or on PPI had about a 50% incidence of dysplasia or cancer. So it looked pretty convincing by the base of this sort of case series that maybe surgery made a difference. But the gastroenterologist said, no way, it does not make a difference. So I asked Eugene Chang and Blair Jobe, who was with me at the time, to sort of put together this paper. And so the world's literature was scrubbed, and it's kind of a small graph down in the corner. But if you just look at the overall data, there is an appearance that surgery has less likelihood of progressing to cancer, but this was not statistically significant in controlled trials and when added to case series. So the conclusion of this was, while there may be a benefit, there is no proven ability of surgery to reduce the creation of cancer in Barrett's esophagus. And that's certainly been our experience since that time, many patients having developing cancer after Nissen. The other thing I wanted to point out is sort of just talking about your mistakes and talking about things, as I said, that may not have gone so well, or what you've learned as you do as you gain experience. Tom DeMeester, who was one of my sort of mentors in this area, said never publish your bad outcomes. Said always talk just about the stuff that goes well. But I didn't believe that. I said I think you really have to talk about things that don't go so well also. And Lee Swanstrom agreed with me, as did Pat. And so we put together this article on dysphagia, which again has been highly cited in Annals of Surgery. And then a second article that was presented at American Surgical that talked about fundoplication failures and what were the elements that caused failure. And again, what you see here is, this is, by the way, a twisted wrap. This is a herniated fundoplication where part of the stomach is re-herniated. And these, again, were highly cited. After I left, the database was still intact. And again, the database went on for at least 15 or 20 years. I'm not sure whether it's still intact now. But Dan Smith and I think Ed might have been part of this article as well, because he was here at the time, published this article in 2007 that showed that Nissens do fail at about a rate of 1% per year, and the likelihood of needing a redo is about 8% at 11 years. It's very helpful information to have as you're talking to patients about undergoing anti-reflux surgery. So I'm going to finish now with sort of, where have we gone from there? And as Dr. Sweeney described, I went to be chair of surgery for 15 years at Oregon before going over to the dark side of administration, which I lasted about 8 years in that. And I'm very glad as of a year ago to have come back into the OR and resume my practice with two incredible junior partners. But the publishing in the New England Journal of Medicine was always something I aspired to do. And this article was standard setting about radiofrequency ablation of Barrett's. Now, we weren't first authors, but there were only two surgeons on this paper, Blair Jobe, with my partner, and myself. And so this really points out, I think, the importance of collaboration with your medical peers, because they need guidance from surgeons, as well as they need help from surgeons, and they need our perspective on the disease processes we treat. So that was sort of the first. But the one that I'm probably most proud of was a study that Stu Speckler and I ultimately did, and this is sort of a good bookend to that article in 1992, which is now, if you can see, we're almost 20 years later, and we revisited that same question, which is better, medical or surgical therapy for refractory heartburn. And I don't have the abstract out here, but I'll let you go back and read it. But the spoiler alert is that indeed still surgery provided better outcome in patients with truly medically refractory heartburn and stooling. I had fun putting this article together. So I'm going to wind up here, maybe leave a few times for reflections or questions that you may have. And I got to say, looking across this room, I see many familiar faces, but I want to call out one of my partners, John Galloway, right now. I can see John over there, and John was just a spectacular colleague for me, and it's so great to see you. John was a much better tennis player than either you or I, Bob. I'm sorry. whip me regularly. So you know, Emory was and remains at the forefront in minimally invasive surgery, and it was really an honor and a thrill for me to be part of that. You know, but this is just one of many strengths that Emory has, and cardiac surgery, as I said earlier, it's really one of the great strengths of Emory. But it's also been really the nation's leader in portal hypertension understanding and surgical oncology with Charlie and Bill Wood, transplantation with Chris and Tom Pearson. It's just a remarkable center for all of this. And it was a great honor to be able to lead a well-funded multidisciplinary program that was focused on innovation, research, education, and clinical care. And we had surgeons from all over the world coming in here watching, and I suspect we still do, and fellows from all over the world. And it's really been a pleasure to do that. But an ongoing what does ongoing success look like? It requires a commitment to improving the outcomes of surgery. And what we did with minimally invasive surgery was really take a patient-focused approach. The surgery wasn't necessarily doing a better Nissen than an open Nissen, but the experience of the Nissen for the patient was very different. And so keeping a primary focus on patient experience is really very important. And I'm going to stop there. And again, thank Dr. Sweeney, thank Keith, thank everybody in the room for your attendance this morning. And I'm happy to answer any questions if you have any.
Dr. Hunter, phenomenal presentation, really a fantastic walk through what is our history here and your impact on us. I look around this room and I don't think it requires any commentary on the fact that you are a remarkably accomplished person, but you reflect everything that's great about this institution. And I really appreciate, and I know Dr. Sweeney is going to add to this, your bringing this all together into what we honor as a tradition of Emory surgery and the impact that this institution and people like you have had on our legacy on the world. So I'll turn it over to Dr. Sweeney, who I know has comments.
Thanks, Keith. Yeah, John, this was just spot on. So thank you so much for accepting the invitation and then for sharing this. I think what I want to say to everyone in the room, first of all, thank you to everyone in the room for being here in person and showing support for the 100-year celebration and to come to see you. But it's amazing what we've accomplished here. And this is a great, if you will, tour through minimally invasive surgery. What really strikes me, our relationship, if I think of John Hunter, the first thing I think is just a wonderful person. And that really resonates. The question I have for you is, as you've gone through this, it's so easy for us to talk ourselves out of things. How have you been able to persist? What was the strategy as you were pushing envelopes that today we take for granted, but in the 1990s this was really a paradigm shifting and very difficult. What was your how have you been able to push through that? At the same time, you maintain you're just such a gracious person throughout all of this. How have you been able to do it?
Well, it certainly hasn't been easy. I think many of you who were with me through the 90s recognize that there were times when things weren't going so well, and you have to kind of push through those times, and you have to have an abiding sense that what you're doing, is right ethically, it's right morally, it will ultimately, push through the barriers that you may have that are either, practice related barriers, cultural barriers, or just, the need for additional tools and technology. A lot of this development was really helping to develop the technology to be able to do some of these more important and more sophisticated techniques. But it's, you really have to sort of maintain this, maybe I say it best in this last bullet point, this sense that what you're doing is making the experience and the experience of surgery better for the patient. When I look back at our first lap choles, it's on a monitor that's about this big and it's sort of black and white, and we're peering, trying to figure out the difference between the colon and the gallbladder. And you said, "Well, we really did that." It almost shake when you realize that was the situation. But you do the best that you can with what you got. I don't know whether that really answers your question, but I think the second part of your question is you just have to keep your equanimity through all of this, and you have to have good support. I mean, the support I had from John Galloway and Gene Branham and our partners was spectacular, as well as the support from Dr. Wood. You need that. But this was an institution that was willing to take a chance, was willing to support someone who had a new vision, and the residents and fellows rose to the occasion and said, "This is the way to go." It takes a village.
Dr. Hunter, I was a lowly intern when you left Emory. And one of the things that I think everyone knew at that time was that you were a master of education along with being an incredible academic. And those are sometimes really hard things to fuse, to realize that you can be an incredible technician and convey that to trainees. And I guess for the current times, my question really is maybe not one that's answerable, but we're finding that robotics is supplanting the technical abilities of our residents in laparoscopy. There's just so many platforms for trainees to learn. What words of advice do you have for the trainees on how they acquire, what they should be focusing on when they're acquiring their skills to be successful practitioners in the current times?
Yeah. Well, I'm going to tell a story, and then I'm going to come back to your question, which reminds me about, we had a medical student who became an Emory resident by the name of John Brawley. And as a medical student, John was very interested in laparoscopy, where some of the chief residents weren't particularly interested. And John got to be very proficient at laparoscopic suturing. So when he became an intern, I would call him wherever he was when the chief resident was fumbling with suturing. And John would come in and deftly tie the knots, and the chief resident would just get so furious. That's a side story. It's a great point, and it's I think Nat Soper has recently published an article that Nat was a colleague of mine who's now out in Phoenix, which was from pioneer to dinosaur in one career, because he never took on robotic surgery, and I've now not taken on robotic surgery. I'll make that really clear, because I didn't really see a need for it. Now, in the pelvis, I think there's definitely a real need for it. I would advise people to learn both. And I think our fellows now, at least especially those applying to our program, need to and want to learn both. And we have a good robotics program. So I think that's sort of the equilibrium. And there are definitely places where robots are very helpful. But I don't think that we need to do every operation with a robot.
Dr. Hunter, thanks for the visit and a wonderful talk. One of the striking things in your presentation today was about how technology has evolved through a very healthy relationship with industry initially, and now the perspectives and the opinions about industry relationships have changed over the last 2 decades or so. And I was wondering, from your clinical experience as well as from your leadership experience, if you think the pendulum has swung too far in restricting any relationships with industry that may have impact on technology improvement, educating people, whether in the United States or around the world, and developing this technology further. I think, nowadays it's very unlikely or very hard to kind of get a grant from a manufacturer that would fund relationships such as this to develop the technology further.
No, I recognize that, and I think some of that was a reaction to some real conflicts of interest that developed during the early days of laparoscopic surgery. I mean, there were individuals who were receiving kickbacks when a laser was sold in the course of after having gone to one of the courses and learned how to do laser laparoscopic cholecystectomy. And so I think this sort of arm's length distance is very healthy. It doesn't mean that you can't participate. It doesn't mean that there aren't mutual and shared interests that can be handled ethically. But I think, so there's no doubt that it is more difficult. I actually just joined the data safety management board for a device that will, maybe I can't say exactly what it will do, but it's a new device in the cardiac sphere, which will require some laparoscopy. And that, again, supported by industry, very healthy connection, very transparent, very, so I think this still exists. And I think the guidelines, while maybe a little more onerous, are also a little more healthy and preventing the conflicts from developing. But I think, I guess the advice that would be sort of look around and try to find out where there are shared interests, and is there a new device that will make surgery better, and the venture capital is there to support these studies, and they're very expensive studies to do, but they are done. And I mean, we published one on the TIF, which is endoscopic anti-reflux valve, which was well funded by industry, but again, published in gastroenterology. So that it's still doable.
John, great to have you back. I really enjoyed reflecting on our nearly decade together, early part of my career, and it's so fitting for you to give this lecture. Maybe following on a little bit from Jonavie's question. So one of the things that you've done so well is help people develop as fellows and faculty members and help them really advance to national leading careers. Maybe the environment certainly has changed, but in many ways, some things are the same. You've done that so well. Maybe reflect for division chiefs, young faculty members, the way that you helped people, or the principles and the approach that you've used, and what holds today, and what have you changed in helping people advance to their full potential as faculty members?
Well, Chris, thank you very much. There's for that, and again, so much fun to work with you over that decade. Yeah, I think that there are two elements here. So one is the on the ground element, which is the day-to-day working and supporting the development of individuals clinically and in the academic sphere. That's what you all do on a regular basis. I don't think there's any deficiency in that. I think the second piece, though, is really sort of the mentorship piece, especially after the fact, which is to say that you don't lose track and you don't lose touch with people just because they go to a different institution, or just because they follow their career, help them along as they go through their career, and keep this a lifelong connection. And I was, I got to say that this was not something that I learned on my own. This was taught to me by Frank Moody, and Frank Moody was that person for me. Frank was my chief in Utah, and left when I was a second-year resident. But yet Frank followed me through my career and helped me get into the American Surgical, helped lots of different things that ultimately lead to you being asked to be a chair of surgery somewhere. And so I would urge that you keep track of your mentees, keep track of your students. You'll know which ones are shining, and help get them into the societies that will lead them to national prominence, help them with papers and presentations and annals in the New England Journal and the American Surgical. I don't know whether that answers your question, but that's kind of what I did.
So I'm going to turn this over to Dr. Sweeney for closing comments. I'll note on the eve of my 20th anniversary as a faculty member, just to make Charlie feel old. And I think about the way you just elegantly connected all the threads, and I look at this room full of people and think about how we connect all the way back to the decades of even Dean Warren, Dr. Gallery, Dr. Larson, yourself, and how we all ultimately will be interconnected years down the road. And I look at the back of the room, which has a large preponderance of the younger folks. Thank you for doing that so elegantly, and I'll give this over to Dr. Sweeney for closing comments.
Thanks, Keith. If anybody got a phone, take a picture of this, I really would appreciate it. But I wanted to give this to you, John. It says to John Hunter, in recognition of delivering the Centennial keynote address at Surgical Grand Rounds on June 12th, 2025. Thanks first of all, for your friendship but all that you've done for Emory surgery over the years. And as you said, even though you've moved away, you're still part of the Emory fiber. I'm incredibly grateful for you being here. So thanks very much.
Right next to my desk, and now I'm in a little tiny office, by the way, much smaller than any office. So every time I get a promotion, I get a smaller office, but this time I really have a small office and I love it. But I have the picture of the Amerson Teaching Award. It sits right next to my desk, and this is going to go on the other side of my desk. So thank you so much.